Hi everyone, I'm not actually Mimi Borrelli. She couldn't make it today because she couldn't make it today due to some unfortunate circumstances, but I will be speaking on her behalf. I'm Shruti Jayakumar, I'm also a medical student at King's, and I'm going to be speaking about pain management following cardiac surgery. So 30 to 75% of patients report moderate to severe pain post-operatively. Unfortunately, this pain is often under-recognized and under-treated. Inadequately treated pain causes significant patient distress, impeding recovery, increasing hospital costs due to increased length of stay, and contributing to the development of chronic pain. Protocols designed to improve pain management in cardiac surgery involve individualized, stepwise, multidisciplinary approaches using optimized analgesic regimens. These have been found to be effective in improving pain management in 2 previous single-center studies. And using this, a protocol was designed by the anaesthetists at King's College Hospital to improve analgesic control in post-cardiac surgery patients. Their main recommendations for this was a preoperative dose of gabapentin in all patients, 600 milligrams, and dividing patients into either high-risk or low-risk groups for pain based on IV drug use, chronic pain, or chronic use of pain-modifying medications, including antiepileptics or neuroleptics. And those patients were at high risk for pain. Those that had high risk for pain were also to be given PCA opioids. And the nursing team were instructed to call the pain team if the pain score ever exceeded 8 out of 10 in any of the patients. So the aims of this audit were to, 1, assess whether the protocol was implemented, how effective the protocol was, and also analyze the factors that predict pain in this group of patients. 50 patients were recruited into the audit, and they underwent both urgent and elective cardiac surgery, but they all had a midline sternotomy. Data recorded included their pain medication, their risk for pain, as previously mentioned, and their pain scores at rest, on coughing, and moving on the first 3 post-operative days using the numerical rating scale, 10 being the most severe pain and 0 being no pain at all. A univariate and multivariate mixed model linear regression was also done to model pain on rest and coughing and moving. So this shows, the first question is, was the protocol actually implemented? Now, only 56% of the patients actually received the preoperative gabapentin. Out of the 15.6% of the patients that were identified as high risk for pain, none of them received different analgesia despite their different risk profile. So low risk and high risk patients both received identical analgesics, and none received PCA, patient-controlled analgesics. Pain was greater than 8 on 36 occasions. However, the pain team was only called twice when they were supposed to be called every single one of those times. So this is a graph demonstrating the number of patients that had a pain score of greater than 8 out of 10 at rest, moving, or coughing on day 1, day 2, and day 3. However, as I mentioned, the pain team were only called twice. Now, the second question we asked was the protocol effective? And to answer that, we defined unacceptable pain as a pain score of greater than 4 out of 10 at rest, or greater than 8 out of 10 on moving and coughing, using previous literature. Now, this graph shows the percentage of unacceptable pain across the 3 postoperative days in which we assessed pain. And as can be seen, on the first postoperative day, 37.8% of patients reported unacceptable rest pain. 27% reported unacceptable pain on coughing and moving. While these did decrease over the following 2 days, they still remained high. Thirdly, we looked at the factors that predicted pain in these patients. In the univariate and multivariate analysis, post-operative day was a strong predictor of both rest and coughing pain. Now, pain decreased in the low-risk group from day 1 to day 2 to day 3, as you would expect. Risk was important for rest pain, and higher-risk patients had more pain at rest and actually had increased pain on day 3. The multivariate analysis showed a trend towards a significant interaction between risk and post-op day pain. Age was also important for explaining pain on moving and coughing. So older patients tended to report less pain on coughing and moving than younger patients. So this is age, and this is the pain score, and as the age increases, you can see the pain score goes down. It was interesting because gender actually had no effect on the, no significant effect on the pain. So the main conclusions were that the protocol was not followed in the majority of cases. Post-operative pain differs in high and low risk groups, as well as in younger and older patients. Our main recommendations following this audit is to improve implementation of the protocol that we've created, re-audit this, and then further assess the factors predicting pain. We'd also like to recommend that pain should be measured at rest, on coughing and moving frequently, and all patients should receive individualized pain management protocols. Thank you very much.